sorted now. So a very good evening, everyone. I welcome you all to the second episode of Policy Circles webinar series, Delhi Dialogues. This webinar is presented in partnership with Niti Aayog. Today, our panel of experts will discuss the economic impact of COVID-19 on middle-class Indian families. Now, it also includes rising out of the pocket expenditure, the points which we will cover today, that has pushed many families into poverty. Without policy support, many more Indian families will be financially ruined. The need of the hour is to cut in out-of-pocket healthcare expenditure amid stories of profiteering by private hospitals. Among the other topics which will be discussed today are the economic crisis triggered by COVID and the resultant job losses, the best practices from other countries to protect the vulnerable sections, ability of the government insurance schemes such as Ayushman Bharat to soften the financial blow on households, and whether the personal health insurance cover will ease the financial burden on the middle class. We today have a panel of eminent speakers who will share their opinion on these topics. Let me first introduce our speakers. We have with us Dr. Antony KR, a pediatrician and alumnus of St. John's Medical College, Bangalore. He has worked with UNICEF India for 16 years in Odisha, UP, Andhra Pradesh, Karnataka, and Delhi. He retired as Director, Health Resource Center, Chhattisgarh. Currently, he is an independent monitor with the National Health Mission. A very warm welcome, Dr. Antony. And we also have with us Ms. Shailaja Chandra. We are indeed very obliged, ma'am, with your august presence today. Ms. Shailaja Chandra was secretary in the Ministry of Health and later Delhi's only woman chief secretary. She has served in union ministries of Defense, Power and Health. After retirement, she has taken several full-time assignments, including as the chairman of the Delhi Public Grievance Commission, the first executive director of the National Population Stabilization Fund, and as a full-time member of a Yamuna Monitoring Committee set up by NGT. A very warm welcome, ma'am. Also, we have with us Mr. M. Nagaraja Sharma, who is the chairman cum managing director of United India Insurance Corporation Limited. He is also Secretary General of General Insurance Council. He is a postgraduate in economics, graduate of law, and an associate member of the Insurance Institute of India. A very warm welcome, sir. And Mr. Ravi Duggal, who is a sociologist, public health researcher, and activist associated with People's Health Movement and the People's Budget Initiative. He has degrees in sociology and management. For over 4 decades, he has worked on public health issues, health policies, systems, and financing. A very warm welcome to you, sir, too. A very warm welcome to all our panelists. Also, I extend a hearty welcome to the audience. After the presentation by the speakers, you could ask questions to any of them. Please send your queries through the chat box, not through WhatsApp or any other messaging service. This is a polite request to all of the audiences. Now, before commencing the show, I would request the audience to kindly everyone mute themselves when the speakers are giving their presentations. I now invite Dr. Antony to take the charge of the session.
Good evening, friends. My name is Antony and I speak now from Cochin. And today let me start my screen share. Yeah, is my screen visible to all of you?
Yes.
Absolutely.
Yeah. Okay. So this evening we are talking about what is the amount of health sector financing and how did it reflect during the pandemic and what the ordinary people, especially the middle class and lower class people, how they face the difficulties and how to protect them from the financial ruin. See, as I used to talk about in many other seminar, the previous seminar also, the coronavirus taught us many lessons. One is it's like a CT scan or an X-ray of the chest. It completely exposed what is the strength of the public health system is its vulnerability or fragility. And we knew it was fragile. We knew it for some time because it is a result of accumulative neglect of decades in underfunding, understaffing, infrastructural, and lack of technology upgradation. This all resulted in a poor clientele and even people bypassing the public health system and resorting to private health system. But what the pandemic proved is, it's also proved beyond doubt its relevance and its essentiality, because the nation needs it and needs it with an immediate upgrade and expansion. Why? Because it is the only option for the poor and the marginalized. We can't rely private sector fully. During the pandemic and in a crisis, its shutters were down and the gates were closed. So in the last webinar, Dr. Abhay Shukla, Jan Swasthya Abhiyan, or People's Health Movement in India, he said one statement which attracted me was a weak public health system and a high level of privatization. Both are injurious to health. And I will be talking about what happens when the public health system is weak and what if the privatized healthcare is given an unleashed feature. But before we get into that, let me ask 4 fundamental questions. The question is, whose healthcare are we talking about? Is it care of the privileged few, or is it healthcare for all? Health for all, and that was the dictum, and that was the motto during 2000. And by 2015, we will achieve health for all. And when you say health for all, it is not just equality of healthcare, but it is more of equity, and with a special concern for the poor and neglected and the voiceless and marginalized. So this is one question. The other question is, when we say healthcare, is it a marketable commodity to purchase it and everybody's purchasing capacity for it increase, or is it a public good which should be given to all citizens of the country? So if you agree that it is a public good, it is not a marketable commodity, then the third question arises, who will do it in a democratic country? A democratic country which declared itself as a socialist republic and a welfare state, then it has to be by the government. And that because the government is for the people and by the people. And we cannot expect a private sector to come and charitably approach to give it or do it fully. They might join. Then who foots the bill? Who should bear the cost? Of course, the government of the people. And where do the government get the fund? It is their own taxpayers' money and not an insurance agency. So in the last decade, we were talking more of from 1978 in Alma-Ata Declaration, we were talking about primary healthcare. So that primary healthcare had 8 components and we were focusing on that, various moments. But in this decade, after 2000, we are talking about a universal health coverage. And that is, world body has realized it is essential component and it is a critical component of sustainable development, and it is needed for the ultimate reduction of poverty and reducing social inequities. India also is striving for all these by our constitutional mandate, and universal health coverage then cannot be achieved by a third party or reliance on some crutches and support systems like insurance package and roping in private sector, asking for the mercy and things like that. Government has to own up the full responsibility for it. If you have that universal health coverage approach and public health system playing the key role, then the image of the public health system improves and there will be all your client will increase. People start coming back. For example, in Kerala, the utilization of public health system was hardly 28% in 1992. And it increased by 2020 to 48%. So if and this has happened in Tamil Nadu, this has happened in Gujarat, this has happened in Himachal Pradesh, and many other states wherever public health system delivered the goods, people flock to it. May not be the case in Bihar. And who made that change? It is National Health Mission from 2005 onwards. It made a difference. And recent addition, the health and wellness centers, really made a difference. It's making a difference, just starting now. Ayushman Bharat and Prime Minister's Jan Arogya Yojana and some public-private partnership had a role, but how much of it is debatable. Now we said a universal healthcare requires some funding support, and that cost of healthcare has to be met by the government. That is because it has to be, that is to protect the people from financial hardships. When healthcare expenditure by government is very low, that is shifted to each individual, and their out-of-pocket expenditure goes up. This is done because financial hardship will lead to push them into poverty or pawning their gold ornaments and financial savings, and that should not happen. In a democratic country, healthcare must be from a pooled resource, from healthy people pulled into that resource more for the spending of somebody who is weak and unhealthy. That is the whole principle. And that cannot be left to the vagaries of market forces or to insurance sector. One is the insurance sector with all its effort and canvassing, it is poorly enrolled, and some of them, the claim settlement ratio is so poor and it is poorly reimbursed. Other speaker in the panel will come to that efficiency of insurance and other aspects. Even the latest National Family Health Survey 5 shows among the states the data is available. In Bihar, the insurance coverage was just 14.5%. Maharashtra is a huge state, is only 20%. Karnataka is 28%. So in these states where the data is available, the National Sample Survey NSSO data shows the out-of-pocket expenditure during admitted cases, not the outpatient, in private hospitals in these states were almost 7 times in spite of the insurance. Now, to avoid that, there should be a better health budget allocation. Now, poor spending by government gives poor returns. So per capita health expenditure was varying state to state, and even for 2-3 decades, it is going on the same way. We expected this time, in the midst of pandemic, we will have a big allocation for health. We expected around 80,000 crores for health, but if that is the case, we could easily set aside about 60,000 crore to the National Health Mission, which is making a difference in various states, apart from the state health budget. That did not happen. Yeah, we had a 35,000 crores extra allocated for vaccine, and even that is very lowly spent. It was not utilized in time for advanced purchase of vaccine. That is a sad story. Globally, the proportion of GDP for health expenditure is 5.99%. So all the health activists and people's health movement were demanding a 3% GDP for health sector in India, and thereafter incremental increase slowly from 3 to 4 or 5, like that, to reach 6%. On the other hand, what we have seen over the years, the proportion of GDP for health budget was a token 1.4% in 2009-10. It went on decreasing in 2013-14, 1.2, and 15-16, 1.15, and in 16-17, slight increase to 1.18, and 18-19, 1.3, and last year also is about 1.3. So where are we with regard to a minimum expected expenditure of 6% of our GDP? Now, if that much is spent, there is a wide variation, interstate variation exists for decades. Even from the beginning of this century, 1999 and to 2009 decade, our total government expenditure averaged around 4.4%. And we were in the WHO's ranking of 191 nations, we were at 183rd rank, in which even state to state variation was as low as rupees 93 in Bihar, with a rich, mineral rich state and with all sorts of agricultural income quite good, that state, to Himachal Pradesh having 630 in 2004-5, before National Health Mission started. The out of expenditure, what happens then? The study done by Kerala State Science and Literature Society, Kerala Shastra Sahitya Parishad study in 2011, and they studied, and out of pocket expenditure per person increased 60 times over a quarter century, from rupees 88 in 1984 to rupees 5,679 in 2011. And if, of course, that expenditure rise, out-of-pocket expenditure, was mainly because of the high cost of antibiotics and some of the newer generation antibiotics and diagnostic test, which is advanced, and for everything, irrational use of diagnostics, especially medical technology application, or like CT scan and MRIs and all used, and their out-of-pocket expenditure was going up like anything. It was not state funded. So WHO says, if your out-of-pocket expenditure is more than 15 to 20%, that can lead to impoverishment. And that is what happened in India. India had, for the nearly from 2010 onwards, till last year, it is around 61% India's out-of-pocket expenditure. Even in admitted cases, PMJAY did not make much of a difference in the admitted cases. That's what we are saying. Some of the studies show. I'm not going into the details of that right now. Now, what happened during this pandemic? It was a market disaster. And then everybody knew, including the courts of India, knew that there is an urgent need for regulation, and there is much more accountability from the private sector. There was a Clinical Establishment Act from 2010, and it was been approved and endorsed in 11 states, but no serious implementation. Central government was lethargic in regulating the private hospitals or promoting patient rights in any form in this pandemic. Of course, there are other serious things to do, but this was a burning issue too. National Human Rights Commission issued 2 sets of health and human rights advisories. One last year during the peak of our first wave, September 2020, and again in this May 2021, asking for observance of patient rights charter and a rate capping in private hospitals and a better, more efficient grievance redressal mechanism. The courts have to step in. There was a judicial activism, thank God. There was a reserving of COVID care beds in private hospital by Karnataka High Court. Thereby, a remarkable change occurred in many private hospitals in Bangalore that beds are reserved for COVID care. There was a capping of prices for PPE kits, bed charges, and ICU care, and what you charge per day in the bills. And there wanted a breakup of discharge bills, what is said by Kerala High Court. And Delhi High Court also intervened in a seamless movement of medical oxygen across neighboring states like Uttar Pradesh, Madhya Pradesh, and Haryana to enter Delhi. Why do we have the court to intervene in this? I mean, it is good that they have intervened for salvaging the situation. And there is a regulation of treatment practices through a standard protocol has not been ensured. And it so resulted in a huge black marketing and of remdesivir and overuse of remdesivir for whatever it is worth. It is of doubtful value except when it is used in the high viremic phase, and where there is an oxygen demand, and only in admitted cases, not as a routine in mild cases. But somehow people felt it is a magic drug, and that's why $6 worth of remdesivir was sold at $300. And the misuse of steroids, luckily steroids is not that expensive. Around 15 states governments involved another law, National Disaster Management Act, and laws to it to regulate rates of COVID treatment in private hospitals. Maharashtra government capped the charges of 170 medical procedures with clear guidelines, which gave an armament to some of the civil society organizations to fight for. I'll come to that. See, what's the pandemic experience? This was not only in India, even globally, during a people's health movement, global people's health movement webinar I was listening to. And Italy had the same thing, because Italy had outsourced the entire thing to private operators, and those private operators were not interested in public health institutions. Old age homes and how to prevent cases in old age homes was not their concern. They were only interested in giving care this many number of days in the ICU care and providing ventilator support and things like that. They were not interested in prevention or control of communicable diseases or testing in epidemiological investigations, because it is all government's job. They did not want. The reason is there is no profit. Similar was the experience in Uttarakhand when I visited as a part of National Health Mission. I saw in Rishikesh a PP signed, and that PP signed party, they were not interested in immunization, family, birth spacing, or any of the public health activities, but they were only interested in how to increase the number of X-rays, scans, and things like that. There was a much acclaimed Chiranjeevi scheme in Gujarat. But what happened is the whole Chiranjeevi scheme was beneficial to the private hospitals in Ahmedabad, Surat, Baroda area, and it crushed the public health system. Well running, some of the public health hospitals were, there was no client there, and everybody was going to the private sector because the government is paying for their care in the private hospitals. But the same under the Chiranjeevi scheme, entire Ran of Kutch area was neglected. So they won't come into areas which are difficult. Spain had 25% of the health budget for set aside for private health sector, and all were operating on PPP. And they were more in favor of, even people's representatives more favor of making laws convenient to the profit of the private sector. And during Corona pandemic, it was a disaster in Spain. We all know the thing. Given a chance, private sector will not miss an opportunity to overcharge. That is what happened in Pune. There's a civil society organization, Sati in Pune. They had appointed patient advocates, little legally aware activists into, and all discharge patients' bill was scrutinized, and the discharge bills were audited, and they came back with the Maharashtra government order, what is the overcharging, and those advocates got, at least in 6 patient cases, 5 lakhs refunded. It may be a small effort, but it shows a trend how the private sector bills have to be audited and scrutinized, because the innocent people out of emergency and compulsion of circumstances, they pay the bill. Otherwise, the dead body won't be released or patient won't be discharged. This is a bad experience. Now, in this, Dr. Abhay Shukla again said, there is a much propagated, advertised invitation by the India government to private sector overseas to come to India and have, this is a great business opportunity. And is it the time during this pandemic we have to advertise this? Does it require a rethinking? Foreign investment in hospital sector has increased over 100-fold from 0.3 billion in beginning of the century to 39.9 for almost 40 billion in 2013-14. It's good. Okay, you get in the interest of tourism, foreigners come and get the services in India. It brings foreign investment and income. And but what it sets a model for other Indian private sectors to make money in a different manner, that's not good. 5 large hospital chains, Apollo, Fortis, Narayana, Max India, Healthcare Global, let me name it because it's an open secret, had combined reported revenues of 129 billion in 2017, an increase of about 80% in 5-year period. The increasing role of financial motives, financial markets, motive of financial actors and financial institutions, all emphasizes a generation of revenue and economic efficiency. That's a business model. But is health a business model in India? Pandemic time experience was large-scale overcharging, irrational care, and other negative behaviors by the unregulated private sector in India. See, for example, even there is a comparison. A Delhi corporate hospitals PP charges was per day is rupees 10,000, wherein in another city in Mumbai, a charity hospital could do it only 3,000. So where is 3,000 and 10,000 per day? In summing up, I would say we need a rethinking in all these. And some lessons we have learned. One is much of the cost and hospital visit could be avoided if telemedicine has as an effective tool and a legal sanction for cutting the cost for health promotion activities, advisors, follow-up of non-communicable diseases, mental illnesses, counseling, palliative treatment, much of it could be replaced by telemedicine and to avoid a unnecessary hospital visit. One thing we have already proclaimed in the last 4 years, that free drugs and diagnostics under the National Health Mission. Ensure availability of free drugs in public health institutions and through web-based, without tender bidding and web-based tender bidding and bulk procurement, which Tamil Nadu has shown through Tamil Nadu Medical Services Corporation, which bulk procurement, the generic drugs the rate comes down. So that's a good model. And there is a PMJY also aims at it, and it is currently about 66 crore people are into it. Every state to have a public sector production unit of antibiotics. Many Hindustan Antibiotics Limited, many public sector antibiotic production units are closed. Many vaccine producing centers in Chennai, Ooty, and Kasoli were closed by the previous health minister. I don't want to name, but why it was closed? Put in, relook at it, upgrade its technology, put in some money so that it becomes world class and we could produce in public sector those essentials. And essential medicines can be produced in public sector. Some states like Kerala are trying, making a step towards it. Enforcement of Clinical Establishment Act in all states. Regulation of private sector. One, for quality of services. Okay, in private sector, you have to pay. People are, clients are ready to pay, but do they get value for the work, money? The quality of care. Do they get the medications and treatment as per the standard treatment protocol? But all rational doctors agree. Is the price is genuine? Those are the things in the Clinical Establishment Act we have to look at. Court orders on have saved during the pandemic, but it need not be repeated. We must have systems in place to check this, and so that this crisis, such crisis period is not repeated. And National Disaster Management Agency also work closely with disease control centers like NCD so that we have clear protocols and steps well in advance, even for the case of liquid medical oxygen production and things like that. We could reduce the expenditure if these production units are in the public sector. And another lesson Kerala and to some extent Odisha has shown is more allocation of funds to local self-governments, be it Gram Panchayat, municipality, or big corporations like Bangalore municipal corporations and Greater Mumbai, who are in planning, delivery, and monitoring of health services under them, including disease outbreak control. I will leave at this and let us listen to other speakers and then we have a discussion. Anyway, thank you, Corona, for teaching us many lessons. Thank you.
Thank you so much, Dr. Antony. I would now request Ms. Shailaja Chandra to kindly give her presentation.
So, good evening, everybody, and thanks for having me here today. It's very, I would say the presentation of Dr. Antony was definitely very candid and to the point. I just wonder, having listened to prescriptions, I think, for the better part of my life, we have such good ideas, but the implementation leaves a lot to be desired. So I'm not going to give recommendations. I'm going to only share, number one, what is this whole thing called the private sector? We have our own notions of what is private sector. Are we talking about chains? Are we talking about small nursing homes? Are we talking about the unqualified medical practitioners? We are all private sector. And one should have some clarity about who you're talking about. Second is the government's role and the fact that people are paying out of pocket, not now, but for decades. And that is because of very low investment in health. Year after year, budget after budget, promise after promise, nothing gets done. So if you're not willing to invest, then obviously one will have the kind of low rankings that one has seen and which Dr. Antony alluded to. So that is not something which we can really debate upon. But what we can do is to look at some of the things which happened during COVID-19 of 2020 and 21, and what lessons can we learn from that. I would say that this is not a government versus private or public sector versus private sector story. And I have a number of slides, not too many, maybe about 10, 12, which are very explicit and have been done with a certain amount of research by people who are interested in this. And I've given the sources. It is not a research paper. It is not a Ravi Duggal paper. It just gives you an idea. But before I go to the slides, I do want to say that we should have some clarity, because if you look at, say, we were able to look at a range of about 180, 200 districts. In the country, the COVID beds of the private sector, I mean, allocated through government orders or through whatever mechanism, it was 44%. The rest was with the public sector, district level. Even so, what really came out was that the occupancy in the private sector was much higher than in the government sector. So that really questions when you are desperate, it's a matter of life and death, you aren't going to think of how to save your parent or your spouse or your child. You're not going to think of money to the extent that, I mean, you have that money to spend. And that is why there is a kind of a you might say demand from the private sector, that from the public, that if push comes to shove, they will go to the private sector, even if it costs money, because the standards and quality in the public sector leaves a lot to be desired. Now, before I go to anything, I want to share with you, many of you know it, but I think it bears repetition. The Mumbai model of how they managed COVID is just brilliant. And I'm so proud that India and one city managed to do it. And I was very doubtful in the beginning. I did not have much faith that this was working. I'm not living in Mumbai, but I am a Maharashtrian. So I do have links with people. So it was possible to counter check. So I started out by asking not the commissioner, Iqbal Singh Chahal, because he's a very public figure and would always give the good news story, but lower levels than that. And I think, having been an ex-IAS officer, we know which buttons to press. So I went down to levels which matter. And what really stood out, the Bombay Municipal Corporation had divided, or it already had divided Bombay into 24 wards. And each ward is self-sufficient in itself. It's like a little municipal corporation on its own. Now, they had a common website. Everybody's names, addresses, everything is over there. Every time there was any kind of a requirement for a test report, they ordered and they tried to, I mean, the court was asked to intervene, but nothing came out of it, that the report would not go to the patient or his family. It would go straight to this website, where the people in charge of the 24 wards had all the authority to be in touch on telephone, to be able to send an ambulance. And how they created 800 ambulances is really, I mean, remarkable. That, I mean, if there's time, I'll tell you about it, but it was something which we must think how to do things imaginatively. So the ambulance would go, they would check the patient, they'd say, you appear to be a case for hospitalization, you appear to be a case for home treatment. The hospitalization cases were just bundled, and the bed and the place was earmarked depending on whether the patient said private or government. That choice he had. If he said private, then it was for this particular 24, you might say, one ward, to decide which was the nearest place which had a bed. And all that was on a website. They could earmark, slot this person, Mr. Kulkarni, and Mr. Kulkarni would be taken to that hospital. So number one, that happened. And if you want, there's an article, a very simple article I wrote for the Quint, which brings this out. It's been published. Second was that the entire, you might say, costing in the public sector was free, but in the government sector, you would pay according to whatever that facility charged by the rates that were prescribed. Now, that worked extremely well, because the public did not have to worry about which hospital, which bed, which doctor, which ambulance, which drugs. It was all taken care of and monitored by this mini municipal corporation, 24 of them. Now, this is something which makes you realize that in a crisis, it is possible to do this if you have the will and the wherewithal. If you just have neither, nothing is going to work. And it works only in urban areas. This is not India. But Mumbai is a population, something like 16, 18 million, and comparable to the, you might say, the urban population of Delhi, which is more, in fact, 2022, people say, a million. But definitely Delhi was in a mess. They had not done any planning for oxygen, which Mumbai had done right from May 2020. They had given out tenders, they had the oxygen supply from whatever the unit was, going in pipes to the beds in the public sector that had been already laid out. They had given out tenders for PPEs, which many states, even Odisha had given out tenders. Kerala had given out tenders long before this became such a big thing, because Kerala had had the experience of Nika, so they Zika, and they had not Zika, sorry, Nika. Am I right, Dr. Antony? Nika. Okay, whatever it is, they had had that experience. So Nipah. They used to go and they went and ordered all this. So you had states which had tremendous imagination, initiative, without waiting for all this top-down orders. That's one side of it. That's the good news. The bad news is that the kind of coordination one expected, it was there in 2020. I talked to several health secretaries, 6 of them, and I wrote about it. I even appeared on television saying it, where they were absolutely in the saddle. They said, we talk daily to the Union Health Secretary, we get inputs, we are told how to do things, and the lockdown was being used largely for ramping up the capacity to find your people, quarantine them, isolate them, take over these dharamshalas, take over the health resorts, make them into centers at the district level. And the Bilaspur example in Rajasthan is absolutely, I would say, positive and brilliant. That fellow, I was talking to him around 25th of March 2020. And he already was able to ensure that the kind of, you might say, cordoning off of the district to prevent people from coming in or going out, and 2 million population house-to-house visits took place, and they were able to stave off. They had about 13 deaths, not a death after that, because this came from Udaipur. Somebody had gone for a party, people had come from abroad, they brought the infection, but he was able to do it. And I didn't believe him, because I am a very hard-boiled bureaucrat. I know where the loopholes are. So I asked him, I said, I want your data. Before I write an article, I want to see which houses did you go to, what are the names, which are the wards, which are, and he did. On WhatsApp, he sent me sheaf upon sheaf of every subdivision of that district and the sub-subdivision and how they were managing it. And it's a brilliant story, both that and the other story is also of Kasargod, which did extremely well. Anyway, so we have good news stories, and yet we went completely amok in many states and many cities. And later on in rural areas, in some parts of the country, it was disastrous. Whatever good chits may be given to anybody, the fact remains that these pictures of dead bodies being thrown around and pyres and bodies in the river, no, they could not have happened. I mean, nobody is going to make up such a thing. And that has to be avoided. Now, let's get back to the bigger picture, which is that I want to put up my slides. And basically, I am not trying to push for the private sector, but do realize that foreign direct investment into the health sector was permitted by government policy. It was permitted with full finance ministry approval, not health ministry. We were nowhere in the picture. I was very much in the ministry when all this was happening, and it was not a decision of the health ministry. We didn't even know it had happened. FDI came, and with it came lots of money pumped in as a business. Remember, it was never for altruism. It was never for charity. It required regulation by the government. And I think I must have written 3 articles by now on the subject that we do not have a regulator. Telecom has a regulator. Electricity has a regulator, and you go from level to level, up, district to state to center, and it works like a court till finally it goes to the courts if everything fails. But I know very well that the regulation is pretty tight, and if the regulation can be tight for these sectors, why can it not be there for health? Instead of blaming the private sector that, oh, they make money and they are extortionists and they are cheats and they are just, sucking patients dry, they will. All businesses do it. It's not special to health. Just because it's health, you don't have to show compassion. Every single business, and Dr. Antony mentioned in some context, he did say that this kind of a tendency to make money wherever it is possible will be made. It is for the regulator to manage this whole thing. There is no regulator. Clinical Establishments Act will never come. Take it in writing from me, Dr. Antony, because even the few states that have done it have not issued the rules, or they have not appointed the people to do the oversight. So it is as good as non-operational. It is because it hits exactly where the private sector should be hit. Now, I'm not talking about corporate sector. I'm talking about the private nursing homes, small fellows. They take anyone off the road and treat him as an assistant. He later on becomes a unqualified medical practitioner. They take any girl, put her in a white uniform, and with a little bit of training, she's called a sister or a nurse. If you have the Clinical Establishment Act, you will have to notify who are you keeping, What are their names? What are their qualifications? And what are the services you're giving? If you're doing only maternity work, you cannot be doing something else. If you're doing surgical, general surgery, you cannot be doing some specialized work. So the Clinical Establishment Act asks for transparency, which none of these private hospitals want to give. That is why IMA has opposed it tooth and nail, and they will continue to oppose it. And governments ultimately listen to where the strength lies. And the strength, the public never takes this up. Like public everywhere is complaining, but they never get together to articulate it. I'm glad that the policy circle is at least trying to give a podium for these things to come out. But anyway, clinical establishments will not come, with the result that you do need a regulatory mechanism and not the consumer courts. They are busy with toasters and with air purifiers, and in the middle of it, you have a medical negligence case also. I don't think that that is the way. You need a proper regulatory system for the district level, state level, and the upper level. Now I'll come to my slides because they talk about insurance, and I am a great votary for the fact that, like other countries, either at source money has to be deducted from people, and that cannot be, I'm not talking about the below the poverty line or the poor. They have been catered for in whatever way it is happening under Ayushman Bharat. What happens, as Ravi Duggal told me, what happens to the middle class, informal, white collar worker? And I'll share with you the details of how large that segment is. They have no insurance cover, and they do not have the money, they say, that even if they're earning, to be able to put in 45,000 or as a premium is something which comes dearly. And if there's a parent to be looked after, then it's really something which becomes, suddenly shoots up from 45,000 to 90,000. So this is something which insurance will have to obviously build in. All over the world, insurance works like that. So it's no use blaming the avaricious and insurance companies. The fact is that if you need health insurance, it is for a certain amount of money. So straight, let's go to my slides. So I'll have to do screen sharing, I think. Can you see? Is it visible?
Yes, ma'am.
Okay, I think it needs to be made into a larger thing. Okay, now you can see it?
Yes, it's visible.
I don't know. It's gone back again. I don't know where it's gone. Anyway, this slide 2 is there. Slide 3, I'm going straight into. Now, this is something, I've missed 2 slides, forget it, they're not worth it. This one is something which you must have at the back of your mind when you talk of private sector. 2/3 of the hospital bed capacity is owned by the private sector in India, the hospital bed capacity. Hospital bed distribution is nearly 62% of this bed capacity is with the private sector. And of the 11.9 lakh private sector beds, the top and large hospital chains, I've given the names below, they account only for 4 to 5% of the beds, while the rest, that is 95%, is owned by smaller standalone private hospitals and nursing homes. So when we talk about the performance, when I share with you the performance of the private sector, which I know about, I'm talking about the 4% to 5%, not the 95%. I have anecdotal evidence what happened in the 95%. Very generally, they folded up when they were very small. If they were just 10-bedded facilities or something like that, or 20-bedded, they just folded up because they just didn't have the staff. People went away. Some opened for certain other things like maternity services and all, because they found they were completely without any kind of work, any kind of earnings. But that was also very small. They were who was permitted to be keeping the COVID patients was very much under government's eye. Of the 95%, how many were allowed to actually keep COVID patients? I don't know. But when we talk about large hospitals, let us be clear that I am referring to Apollo, Max, Fortis, Manipal, Narayana, this Medant and Aster DM, HCG, CARE, and large regional players like your Shalby and Sterling and Sayadri and Amri and Kims and things like that. They are the regional fellows. Now, those certainly fall in this 4 to 5% bracket. Bed distribution is on your left side, and you can see how large the private sector beds are, the bed distribution that is. The blue is 62% and the orange is 38%, which is public sector. Now, the next one is, how do I go to the next one? Okay, let's hope this is the right slide. Okay. Now, what the large private sector did, these are positive stories, these are not negative stories, but they throw up policy issues. First is they did set up teleconsultations. These were facilitated, and I know people, at least in my locality, who have availed of it. Whether they cost 100 rupees a day or 10,000 rupees a day, I'm not going into that. That is for a regulator to go into. But they did facilitate teleconsultations. That helped to have doctors on call 24/7. Where else could you get to talk to a doctor 24/7? They established these flu clinics at the entry, so the employees and the visitors were also screened, which is good because they did it without any instructions from above. They had to be very careful about who they're letting in, but they did it. They ramped up their infrastructure, and I talked to managements in 2 or 3 of these large hospital conglomerates, and they definitely spent the capex money on very fast. They didn't wait for anything else to happen. They got these, they're listed there, laryngoscopes and smoke evacuators and intubation chambers. And they got all these things, the ICUs, the ventilator beds and all were ramped up. We still fell short in Delhi, terribly short, but the fact remains that they did do these things, and all these chains, most of these chains did it, and they did not wait for hand-holding on these things. They also listened to state governments. I talked to the 4 state governments, certainly Kerala and Orissa, not Orissa, Kerala and the second was this Delhi, and then I talked to Maharashtra. In all cases, there was no doubt that the state government had full authority, and in the beginning they shilly-shallied, but later on they exercised the authority. Many states issued very copious orders to the private sector hospitals, and they complied. They didn't sit and say this can't be done and this is a problem, this can't be done. That's a good thing that happened, that they didn't start throwing up their hands and saying it is beyond us, this is not the work we do, etc. And they manage their own PPE and their drug supply. At what cost? Again, I'm not going into. This is not, you might say, a defense of the private sector. It is to show that had this not happened, where were people to go? Except Mumbai, no other state in the country had the networking that Mumbai set up. Nobody had the imagination to do it that way. But wherever it worked, people willy-nilly took a car, took a patient, landed up over there in the hospital. It's not as though all of them had a good time. We know of retired ambassadors who even died in the parking lot. We know that. But within a kind of a, you might say, perimeter of having entered the hospital, there was some way of being able to manage. And I want to share with you a personal example. I got calls from Manila, from a batchmate, and from a very senior person whom I know in Singapore. Both said, please, please help to get a bed. And I tried, no private sector hospital was willing to give a bed. They said, we cannot. There is a waiting list of 400. People are watching with a hawk's eye. We cannot interject somebody from below. They can be on the waiting list, but we cannot give them bed. Ultimately, in both cases, I had to speak to the government setup and beg of them, they need an oxygen kind of a place, a ventilator place. Even then, the poor people had to wait in the emergency for about 2 hours before they were allotted a bed in a government hospital. Things were extremely bad, and I'm talking about Delhi. So I do not know really what may have happened in other state capitals, but Delhi was really quite a disaster for certain days of April and May, certainly. So this is the story of what the private sector did. Again, this is fraught with a lot of question marks. There must have been overcharging. There must have been horror stories about how people were treated. Please don't look on this as a kind of a defense. It is only to say that thank God that India had at least that 4-5%, which did not suddenly throw their hands up. They did something about it. Now, coming to insurance coverage, and this kind of thing has been collected from IRDA, PMJY, and ESIC, Telangana Arogya Sari, and various published articles. I have the links to the articles, but I think that kind of work is much more up the street of Ravi Duggal. It's not my bread and butter, but at least this gives you a picture which you should be familiar with. Now, let's go to this coverage. You can see on the left side, health insurance penetration, the percentage of population covered or eligible under health insurance. This sounds very good, but we know in effect what it means. You see that big blue, the big blue is the government-sponsored scheme, and above that are group policies. Now, if you look at this, one would be very impressed. 74% of Indians are either covered or are eligible for coverage under either health insurance or government health schemes. So the uninsured is 26%, that is 36 crores. People who are white collar, who do not have insurance, who may be self-employed or maybe in companies or in, you might say, non-government areas where there is no insurance offered. This is the middle group that needs, it's not in the middle, but I call it the middle group, which needs to be addressed. Insurance is not really something they have been availing of. How do they avail of it? At the cost at which it is being given, the premium, unless it becomes reasonable and affordable, people won't be able to afford it. The rest of it all is these government-sponsored schemes. Now let us go to those government-sponsored schemes on the right side. You will see that together there is this 39 crore people, 43% are in this Atal Bihari PMJ scheme. And then there are additional families also under PMJ who are about 20 crore. Together, they are 65% of the government scheme beneficiaries. Whoever is getting government benefits through different schemes, they become eligible for this PMJY. So it's a very, very large number. Do they get it? Do they actually get covered in the hospitals? That's a totally separate issue. From the anecdotal evidence I have, this was not a scheme which was, the PMJY was not being used by the public which needed beds under COVID. They paid out of pocket. The outgo from PMJY for COVID was nowhere near what all those long, long lists of whatever you can cover under PMJY spoke of. So that is one side. Then you have central government. Right on top, you have the PSU employees and the CGHS. Then you have the light blue bar, which is the ESIC, which is about 13 crore people. And then, of course, Telangana, Orissa have, hello? Can you hear me? Hello?
We can hear. Any problem? Only thing is,
I'm getting a message that my internet connection is weak, but I'm able
No. We can hear you. Only thing is, we have overshot the time because 2 hours speakers are out. Thank you.
Okay, then in that case, what do you want me to do? I've got 3 or 4 more slides.
Maybe
expedited. Okay. So this is the payer mix, you can see that the cash in the pre-COVID time what it was, and post-COVID time what it was. You can see very well that the TPA went up phenomenally. The orange went up phenomenally in the increase in the TPA insurance. And here, this is something which shows what did an average patient bill you for 1.54 lakhs. What did he get back? 0. So that shows there was quite a sizable out-of-pocket expenditure. And this is huge differences. Then you have the year-on-year collections. The only short point in this is that retail health insurance went, group health insurance came down, and the government schemes that we talked about coverage was in fact completely below, it was minus. Then the lessons learned and the policy, you can see the kind of health infrastructure that was positioned by the private health sector. The first blue line is the oxygen beds, the orange line is the ICU beds, and the ventilators is the green line. So because the period is April 21, 2020 to April 9th, 2021. So in a year, you can see no great improvement, except O2 beds have climbed up now. And the second thing is the ICU beds have climbed up, but not that much. So this was the picture. I'm sure it will get ramped up more. So ultimately, the lessons learned would be building a skilled pool of manpower that is badly needed to enhance private sector participation in Ayushman Bharat. Most of them are complaining that they don't get the tariffs which are even able to pay for their costs. So that is something which needs to be checked. And we have to look at this middle group that I talked about, that 26, you might say 36 crore people who are not insured. What's going to happen to them? I think that's important. And you can see the point that was made, the COVID insurance claim and settlement amount, the state-wise trend is quite different. So one size fits all will not really work. This is basically the kind of stuff I have pulled up, and thank you very much for listening to me.
Excellent slides. Last.
And if you want, this slide is only quotations about all these Bajaj Alliance and Star Health and Insurance Marketplace Policy Bazaar. All of them have said that now coverage under health insurance has grown. Pre-COVID, it was 2 lakh to whatever was happening was about in the range of 20-25%. It has now gone up to coverage of 5-7 lakh. That is a matter of fact. But what happens to people? Where do they get the money? Have to enable people to get insurance, and some sort of the French model. If there's time, I'll talk about it. But right now, I'm closing. Thank you.
Thank you, ma'am.
Thank you so much, Shailaja ma'am. It was indeed a very insightful presentation. I'm sure our viewers, our audience must have benefited a lot of information precisely given by you. Now, I would request Mr. Nagaraj Sharma to kindly come and give his opinion. So I would request you to kindly unmute yourself.
Yes. Am I audible now?
Absolutely, sir.
Thank you very much. I have not made any PowerPoint presentation, so I will be just speaking, and kindly bear with me. And the point is, the topic is the people going out of pocket due to this pandemic. And according to me, the people have gone out of pocket due to 2 reasons. One is the COVID striking one of the family members within the family. And as a result, they had to go to the hospital. And in the hospital, they incurred heavy amounts as the cost, and which sometimes is within their bearable level, and sometimes over and above their bearable levels. They had to sell here, there, or beg and do whatever, and then had to meet the expense. And then there are also, wherever they had some insurance, as Madam has pointed out, the actual insured number is not very high. The middle class who have directly come to the insurance companies and taken the cover, or through their agents. So that is still about 6 to 7% only. Most of it is under the Prime Minister's Jan Arogya scheme or Ayushman Bharat. Under that, or the state schemes like Tamil Nadu scheme, the health scheme, or Andhra Pradesh's, the Telangana, Andhra Pradesh's that Arogya Sri scheme. So these schemes have covered en masse the people. But problem is when you're giving an en masse cover, the sum assured will be very small, because government also cannot afford to give it to everybody a very high sum assured or adequate sum assured. They enter into tie-ups with the various hospitals, mostly the smaller and middle ones. Maybe sometimes by legislation they will force the larger hospitals to earmark a few beds for treating these people who are under these schemes, like the Arogya Shri or Tamil Nadu scheme or whatever. So they say that when they come for a particular serious, maybe a heart operation or a kidney operation, a replacement and all. So they say that you have to reserve some beds for these people also, and then they will pay at the government rates, very nominal rates. So they reluctantly, the hospitals also very reluctantly maintain them, and they do give some service. So in all these cases, they run out of pocket, the patients, when the sum assured is low and the actual expenses are very, very high that they incurred in the hospital for maybe any other disease, or now since we are talking more about the COVID, let's say about the COVID. So they will be going out of pocket. So straight solution is increase the sum assured to a reasonable level. So the average sum assured as of now is around 1.5 to 2 lakhs. The average sum assured. I'm talking about those who don't directly come to us. And in the case of PMJJBY or Ayushman Bharat, the coverage is about less than 50,000 rupees per person. And that's being so low an amount, normally they can't expect better care. So we have to, find fault partly with the people also. Left to me, I want to call a spade a spade. So that's why I would say definitely even our people, the population, are also to be blamed for the whatever mess that has happened in the COVID's first phase and the immediate starting of the second phase. Why I'm saying this? That's because we found awfully inadequate the infrastructure, the government hospital infrastructure, or the kind of facilities, or even shortage of oxygen. Of course, shortage of oxygen and all do happen when suddenly the demand rises to such an extent that no hospital can have adequate, no government can arrange adequate oxygen supply. Just the other day, I was reading some WhatsApp message wherein some doctor has pointed out, if infrastructure alone inadequacy of the infrastructure alone has caused all this, then they are questioning why so many deaths happened in developed countries, in USA, UK, and all. Also, so many people have died. In fact, USA is the highest number. I don't know whether we have already overtaken them in this dubious distinction. So if it is infrastructure, infrastructure and all are planned for a normal situation. This is an abnormal situation. This is a pandemic. And in a pandemic situation, when the infection is so very high, and not naturally many people will find the need to rush to the hospitals, and the hospital beds cannot be developed overnight. After all, they may use the car parking areas, and maybe under the flyovers, they may make some temporary arrangements and put some beds and start treating. But where from they suddenly get the oxygens, required oxygen or ventilators and all. So in this, I blame the people. And why do I blame the people? That's because have these people, have they ever demanded from the government for more number of hospitals, for more medical infrastructure? They always ask for free gas, free electricity, free water, free this, free that, and all. And even in Hyderabad, the GHMC elections happened, that is Greater Hyderabad Municipal Corporation elections happened just last year. And just before the election, the government has announced 50% reduction in the municipal taxes we pay, or for the property tax that we pay, 50% straight away. Those who have already paid, they said in the next year, there will be reduction by the same amount, 50%. And then people voted the government to power. Now the government, Telangana government is giving 20,000 liters of water free to everybody. So people look for this kind of freebies, and politicians who are dependent on votes naturally will try to cater to the needs of the people as they want. Which population, which state, which countries, which population has asked for more health infrastructure, better health infrastructure, more number of doctors, more number of medical colleges? None of them. And when a pandemic like this happens, at least now they should talk about this. They have to learn a lesson and demand from the government for more and more infrastructure facilities, medical infrastructure, and no freebies. Let them not accept the freebies. Otherwise, how will the government, from when you have only a tax-paying small base of taxpayers, direct taxes I'm talking about, how will they be able to provide infrastructure and also the freebies and everything to the people? It's not possible. So instead of asking for a small freebies here and there, they must demand more and more of health infrastructure. Left to me, I would say that government possibly may consider a suggestion, because we have officials from the health department, health sector. In the hotel industry, I find that a lot of time the property owner is somebody, the hotel property owners are somebody, and the people who operate the hotel are different. Like, the Welcome Group taking over, or Taj Group running a hotel. The owner is somebody, and he built the properties, and then he has given the properties on lease to the hotel for a particular period. And during this period, the hotel is managed entire with the entire facilities they manage and run the hospital. So government can also think in terms of developing the infrastructure, build well-designed hospitals and all that all over the country, right from district level and maybe village level, small dispensaries and all, and give them on lease to these doctors who can run them, or give it to some other establishments who can run the facilities there. And because the government has developed these properties and giving not at a very high rate, here again, if you ask me, I'll say on the railway platforms, even when they let out the premises for these canteens, railway canteens and all, the canteen contractor charges you 20 rupees, 25 rupees, very high sums, and then provide a very dirty quality food. Why? When we question this, they tell that what to do, sir. The whole of the money goes in paying the rentals, and they put it on auction basis. And then each one, whoever bids the highest revenue to the railways, to them only they give. So when I am paying such a high amount, and then when they restrict the prices of what I am supposed to serve, naturally, what quality can I give? This is the answer. The same thing should not get repeated when I talk about the infrastructure being developed by the government and giving it on lease to the capable organizations to run hospitals there. So they have to cut down their greed in charging very high rates for that, and rather develop it in the interest of the people, give it a very concessional rate, a reasonable rate on lease, and then the hospitals must be made to serve the people at pre-agreed rates for various ailments, treatments for various ailments. Then possibly we'll be able to have more infrastructure and more of a reasonably costing thing. And as coming to the hospitals charging very high amount, Madam in her speech, although I agree with everything that she said, there's nothing where I don't agree. Madam said that private sector, after all, when there is no regulation, when there is no control, nobody is controlling, naturally they will use the supply-demand mechanism, and then the price gets going up for a hospital bed. It is like an auction going on. So whoever pays in cash, whoever doesn't come with an insurance policy, or if he comes with a very high insurance policy, is okay, welcome. Or if he comes with a small 2 lakh insurance policy or a 1 lakh insurance policy, they say nothing doing. This person is waiting with 25 lakhs in cash, waiting for the bed. So if you want, bring 25 lakhs or 20 lakhs, then I'll give you the bed. That is how it's happening. That happened. So what is required is regulation and control. Because after all, anybody, I'm not blaming the hospital management. Definitely not. I'm not blaming the doctors and nurses. Doctors and nurses have worked beyond their capacities, and then willing to sacrifice their life itself. They worked very hard. So they need to be praised for all the great effort they have put in. I'm talking about the hospital owners, the management, the administration, the owners. So they, of course, they behave like a business house, a corporate business house. Then the prices that here get determined by supply demand. When there is a pandemic, when there is a lot of fear associated with that contagious things, many people, even though they don't require hospitalization, who could be treated at home by as an outpatient or at home itself on teleconsultation, they rush to the hospitals, including that of I mentioned the name of Dr. S.P. Balasubramaniam, the famous singer. He very openly, his family and he himself said, when he was in a position to talk and move, he said he went to the hospital and got admitted just to avoid the disease spreading to the family, to the people in the family. And a person who has a triple-storied or a huge villa kind of a house, and if he himself thinks that he should get admitted in hospital to avoid the disease spreading to the others in the family, then how about ordinary people living in 2-bedroom, 3 bedrooms or small houses? So many people rushed to the hospitals mainly to avoid spreading the disease to the others in the family in order to maintain their isolation. So that is also one lesson we need to draw and keep in mind, that in future, we need to have more and more of such kind of wards, temporary wards, where reasonable facilities are provided, where people who come there for isolation are maintained, and only those who very seriously require hospitalization, they are only moved to the complete hospital. Unfortunately, since I'm from insurance, let me explain to you, there's a lot of criticism. Many people, of course, here you all have been very understanding, and then you are not criticized the insurance sector. But let me tell what kind of criticism we are facing. Many people say the insurance industry has been paying hardly 50% of the claim. They're not paid full claim. That they are talking about an average of the total thing. When we had 28,000 crores of claim, and if I paid about 15,000 crores for the settled claims, there are still outstanding. A lot of claims are outstanding because this treatment is long drawn, and then we can pay claims up to 60 days. After discharge from the hospital, we pay claims up to 60 days, for the 60 days. So they finalize and put all the claim after the 60th day, not immediately. So the claims are still outstanding. So the pending claims out of the settled claim, out of the total claims, we paid nearly 28,000 crores, if that is a claimed registered, initially claimed amount by the hospitals. We registered them for 28,000 crores, and we paid something like 16,000 crores. I'm just roughly giving you an example. It's not that the figures are not absolutely correct, but it's like that. So straight away, the press started saying that, oh, insurance companies are not paying, they are paid only 50% of the claim, not fully. It's not so. What has happened? We claim, ultimately, that was the initially intimated amount. Then the actual bills came in when the claim comes in. And then the bills were, say, instead of 28,000 crores, maybe there were some 24,000 crores. And out of 24,000 crores, there are certain deductions, like, based on the sum assured being inadequate. If somebody has taken a 1 lakh policy and then there is a 3 lakh claim, or if they has taken some 2 lakhs policy, where the room rent per day is only 1%, that is 2,000 rupees per day is room rent allowed. And if he's in ICU, 4,000 rupees for a 2 lakh policy. For a 1 lakh policy, it is 1,000 for normal room rent and 2,000 for the ICU. Now, which hospital has been charging 1,000 rupees for a room or a bed and then 2,000 for the ICU. All of them have been charging very high, very, very high. And as a result of that, all that will go within the policy limits. It is far exceeding the policy limit. So the amount allowed is only as per the policy limit, that only goes. And in some cases where they had 20 lakhs, 30 lakhs cover or 50 lakhs cover, and if the claim is paid only to the extent if the person incurred 20 lakhs, sum assured is 20 lakhs, he incurred 20 lakhs, maybe we paid only 12 lakhs or 15 lakhs. That's again because there is a provision in the policy saying that any amount actually and reasonably incurred is only payable, not the entire amount. Because some hospital, I'm not saying all hospitals, fortunately many hospitals are good, but there are equal number of very greedy hospitals also. They see sum assured and then accordingly they put the treatment online and then they also bill accordingly. If I go with a 20 lakh policy, they see how best to take the entire 20 lakhs. I'm talking about only a few hospitals, those hospitals who are doing this. So please don't jump at me and say that, no, what are you talking? It's not like that. No, I'm not blaming every hospital. There are some hospitals which everyone knows, they go by the sum assured. If I go with a 20 lakhs policy, they try to take the entire 20 lakhs by treating needed treatment and not so needed treatment and everything, and subjecting me to all kinds of diagnostic tests and all kinds of things. So various ways. And all of us know how the billing happens in some of the private hospitals, not all. So they are giving treatment, of course, compared to government hospitals, better treatment. But then they have also made use of the opportunity as expected, and then build very high. So there we allow only what is reasonable for equivalent, because COVID was not existing when these policies were devised. So for the equivalent or contagious diseases, whatever the normal agreed rates are there with the hospitals, we allow only that. So as a result, some amounts don't get paid. So this is how the insurance sector operates. But if you say that should not be, and whatever the insured has incurred must be paid, well, we can pay. That also we can do. But what happens this year? I want to also mention that most of our customers are lower middle and upper middle class people. That is people like you and me, who are basically employees. These are the guys or those who are shopkeepers and small shopkeepers and that kind of a businessmen, small businessmen. And mainly these are the guys who are living, just about adequate for survival, that kind of people. So the premium rates, Madam luckily has already mentioned that when the premium rates are like 40,000, 60,000, if somebody is a very old person, 85 years old, a father or mother is there, and if her premium rate is 75,000 rupees per annum, who will be able to afford this? Yes, you're right. Why have they gone to these rates, these levels? When we started the insurance, the health insurance had gained prominence in India only around early 2000. It is prior to that, it was very, very nominal, hardly there. Mostly we all used to see only government hospital and treatment there. Now the private sector also started just coming in then, and then we also found an opportunity to do health business. So we started doing, and at that time, the premium rates and all were reasonable, and the insurance premiums were also very, very reasonable. Slowly, what has happened? The trend has set in that hospitals started aligning their treatment based on the sum assured in the policy, based on the policy. When it comes to the maternity cases, all of you know that normal deliveries have become a thing of the past. Majority of the cases are becoming more and more cesarean. And then hospital, if you go with a mild heart pain, you're aged around 45, 50, you have some acidic problem or whatever problem, you're subjected to various tests, all kinds of tests, and then instantly a stent is put or a open heart surgery is done. If there are more than one block or two blocks, like they do all kinds of things, and then subject you to a lot of tests and then bill you very heavily. And as per the sum assured. If I go with a 5 lakh sum assured, my treatment gets completed in 5 lakhs. If I go with a 20 lakh sum assured, they will definitely bill me 18 lakhs, nearly at least. So that is what is happening. And then who to correct this? As Madam very rightly said, there is a need for a regulator. If there is a need for SEBI, if there is a need for IRDA, if there is a need for telecom regulation, why they are not seeing the need for a health sector, a regulator for the health sector?
Mr. Sharma, I would beg your pardon because we have Ravi sir waiting. So I would request you to
I'll
kindly
conclude in 2
expedite
minutes.
and-
Give me
Yes,
2
yes,
minutes.
please, yes.
So my point is that if these sectors have a regulator, and all these regulator creation happens through an act. So you read the preamble of those acts, they all talk about the vulnerability and giving an opportunity to the public at large to regulate, control, and to avoid exploitation. Why is there no exploitation in the medical sector? Is there no rampant exploitation? Actually, it's happening here. So is there no need for a regulator here? Why everybody is silent on that? Of course, we have been talking and hearing this now, but why it was not done earlier? So the immediate need is to create a regulator to regulate the health insurance sector. The good hospitals, many of the good hospitals, many of the excellent hospitals who are running great service to the people, like I'm talking about the mission hospitals, some of the mission hospitals, they're all rendering fine service. They are all now demanding a regulator. They all want a medical service regulator because they don't want to be put in the same basket as with the other private sector hospitals. So, my friends, this is what is required in the health sector. There is one more reason, as I told you, why people have gone out of the pocket, that is losing jobs. Losing jobs and shops being shut because of the lockdown, factories being shut, and people, a lot of construction activity coming to a grinding halt. All those people that migrated from villages to the urban centers found it very unsafe to continue to live in urban centers where there is so much of a crowding. They thought it's better to rush home and go home and at least get rid of this crowding, and then try to live hand to mouth, whatever there, instead of living and paying rent here. So trains were not there, so buses were not there, so they had to start walking. And these visuals have been highlighted all over the world, saying that India, as if India has gone to dogs. Yes, press does that. They do. Anybody can do that. But point here is this: why it happened that people were not able to, maintain this. It all happened because of a sudden pandemic, and then the only way of controlling the pandemic was, at that time, rightly felt by the Prime Minister at that time, that there has to be a lockdown, a very strict lockdown, and that resulted in saving. Otherwise, India could have been in Italy. India could have been in the USA in the very first wave itself. But lockdown has been imposed, and because of the lockdown, people had to go home, lose jobs, and become out of the pocket. So, our regulator and also the Government of India, Ministry of Finance, have written to the General Insurance Council and now to IRDA, asking us to devise an insurance cover seeking protection from the lockdowns. If there's a lockdown, the insurance industry must pay every employee that has lost pay, at least for 6 months' wages. But these people, I think, forget that they don't know where the insurance companies get their money from. It is the people's money. It's like a chit fund organization, I tell you, somewhat like, you collect monies from everybody, pool them, and from out of this only, we meet the 3 outgoes: claims,
Right.
our management expenses, and then intermediary charges, whoever is bringing the business. So we meet that, and the money is sufficient to do that. But insurance companies don't have a gold mine behind them or a currency press behind them to print currency and distribute. Why even the Ministry of Finance doesn't realize that? God only knows. So they thought.
I would request you to kindly wind up.
Yeah, winding up.
Because,
So they thought that insurance companies can come out with an insurance cover to protect straight away. So then we had to write to them that it cannot be done. We estimated the requirement to be something like 1 lakh crores as the immediate need, even to give a 3 months protection cover to the employees, 1 lakh crores. And out of, we don't have a 1 lakh crore reserve here straight away. So we can contribute, say, by way of premium, we can collect and then make a pool of 5% out of that, that is 5,000 crores. If the pandemic happens in the very first year, you pay 95 and we pay 5, and together 1 lakh we disperse. So second year, if there's no pandemic, we'll still collect 5,000, and then 10,000 we'll have, and 90,000 you bring it. Likewise, we said it takes 20 years for us to build the reserve enough to meet one pandemic. Why? This is because a pandemic, when it happens, it shuts down the whole world, every nook and corner. Whereas a cyclone happens, it happens only on the east coast of India. The rest of the world is safe. So they all contribute their premiums coming here by way of reinsurance, they come in here. But in pandemic, the whole world gets affected all at once. So there won't be any resource to move from one place to the other. There won't be reinsurance. So these are all circumstances are there. These are all issues are there. So I hope you will keep this in mind, and thank you for giving me this opportunity. I'm still there in case anyone asks any question.
Yes, absolutely, Mr. Sharma. There'll be questions coming up from the audiences. Thank you so much. And now, without wasting much time, I would request Mr. Ravi Duggal to kindly come and give his opinion. And I really apologize for keeping you waiting till so long.
Yeah, actually, I really don't know what more to add, because the three preceding speakers have covered almost every bit of the canvas. So what I'll probably do is basically maybe provide some comments and raise certain issues vis-a-vis some of the points that have been raised, I think, because we've actually overshot our time. I mean,
Right.
I think 6:30 was supposed to be.
We were supposed to wind up our show by 6:30.
I think it's unfair for people who have been waiting to ask questions also. So anyway, very quickly, I'll emphasize first certain issues. I think, as Anthony had also said, that health is a public good, and if health is a public good, it cannot be a commodity, and that is what it should be. And therefore, the role of the private sector gets completely diminished. The role of insurance gets virtually eliminated. Because if health is a public good, it has to be financed by taxes, by social security deductions, and so on and so forth. So if you look at the people who get good health care, even in this country, forget the world. I mean, Shailaja will bear witness to me that CGHS is one of the best funded health schemes, which benefits our central government employees, our parliamentarians, and the government is spending out of taxpayer money over 9,000 rupees per capita. So that's one class of people who get good benefits. There's another class of people who are covered by statutory social security like ESIC, okay, which is actually the lower end of the blue collar working class, because there's an income ceiling of 21,000. If you earn more than 21,000, you can opt out of the ESIC cover. So that's another class of people who have some assured health care. And if they have contributed for 5 years, then they get, with a very small annual payment, they can get cover for life. And ESIC services, like CGHS, there are no upper limits. I mean, in terms of healthcare, I mean, you get everything that is available, is made available to you. Similarly, there's the defense services, who spend as much or probably more than what the CGHS spends per capita. You have the railways, which have a very good healthcare system. And incidentally, railways also looks into public health. It's not only about hospital care and running dispensaries. It's also about public health because there are these huge colonies in which they manage the entire public health of that colony. So railways is a good kind of benchmark because they spend about 4,000 rupees per capita. And various surveys have shown us that if you spend about 4,000 rupees per capita, if that's the government's budget, for example, then we will be close to that 2.5% of GDP, which our national health policy talks about. So as Shailaja pointed out, there's a certain middle class which is left out of the, according to me, there are three types of middle classes. One which I referred to earlier, who get all the social security benefits in government or from under the Factories Act or the ESIC and whatever legislation is there. Then there's another group of people who work in the private sector and where the employers pay for the health insurance. So all the group health insurance policies which are there is basically covering employees of companies, or they may not be employees, but they could be clients also. Like you can actually go through a public sector bank as a client and get insurance which is 1/3 the premium cost which you would get as a retail insured person. So if I have to today, being 64 years old, if I have to get an health insurance policy for me and my spouse for even a 5 lakh, a low 5 lakh cover, the insurance companies will charge me close to 45 to 50,000 rupees, which I can't afford because I'm not a pensioner. I live completely out of my savings and no longer working. So as Mr. Sarma also said, I mean, insurance becomes very expensive, and it has become very expensive. As you grow older, when your needs are more, the insurance company actually doesn't want you. So these are some of the problems. I think Sarma's presentation was very good in that sense that you actually made statements which kind of demolishes the foundations of insurance. That proves that the health insurance design in this country is completely faulty. It's a faulty design because the way it is designed, I mean, having all those, if you're covered for 1 lakh, then you can only get 1% for the beds, whereas the market is kind of exploding with the rising prices and so on. So I think in India, insurance is basically a mechanism which has helped that 4% of hospital beds which Shailaja spoke about, the corporate hospitals and maybe some of the other larger hospitals, let's say 10% of hospital beds to get occupied. You and me will not be able to afford care in those hospitals if we didn't have an insurance cover. Because if there was no insurance, let me tell you, corporatization of healthcare would not have happened in this country. Because there was a point in time when insurance was still very low. I mean, when it was the era of the mediclaims of the public sector insurance companies, that time the occupancy of hospitals, especially the larger hospitals, was less than 40 to 30 or even 30%. When insurance comes in, the occupancy goes to 80, 90%. It is clearly, if you look at actually, if somebody does an audit of these large private hospitals, you will find that they have two major sources of income. One is via insurance, clients who have insurance cover, and the other is medical tourism. These are two large kind of incomes where these hospitals have. So as far as insurance goes, I think for a country like India, it cannot afford the insurance route. So PMJY has faced a lot of issues, a lot of frauds have happened. And it's not, so I think out of that Ayushman Bharat, the one leg which I think should be knocked out is the PMJY. Whereas the health and wellness center, which even Antony pointed out, I mean, gave good examples from different parts of the country. And even I have seen that if you set up the health and wellness centers, which is the second leg of the Ayushman Bharat, if you actually put money, now the insurance part got money from the budget, 6,400 crores. That's the latest allocation for PMJAY. Whereas there's been no increase or no significant increase for the sub-centers budget across the country. Kerala is perhaps one example where a little more is being spent because Kerala converted all the sub-centers into family health centers. And I don't know if they actually increased a lot of the budget, but since you don't get a breakdown in the budget document, it's difficult to assess. So clearly, when you look at India as a whole and across most of the states, out-of-pocket expenditures have been galloping over the years. And probably we still don't have the data for 2021, where we will see, I think, a huge jump thanks to the whole corona crisis, where people have been forced to seek healthcare in the private sector, or they have had to sell assets and so on, much more than they used to do earlier. So we will know that soon. Even the insurance business has increased substantially. I've been looking at the monthly insurance business reports, which IRDA brings out. And my estimate is that the figures are still not out by IRDA, but my estimate is that for 2021, the health insurance premiums, all categories included, would touch 63 to 65,000 crores. It was 50,000 crores in the previous year, but that is where it seems to be going towards. And within the health insurance thing, while in terms of numbers, the government funded health insurance is a huge number of people, something like nearly 35 crores of population covered via the PMJY and other state schemes. But in terms of premium, the government only kind of spends 4,000 to 5,000 crores in getting that health insurance cover for the below poverty line population. So again, this approach, insurance as a concept, the foundation is risk pooling. Now, what happens at the ground level in insurance is that if I know I'm going to need some major surgery or something, what we call cream skimming happens a lot in insurance. So then I will buy, as an individual, I will buy insurance. Okay, now I'm at risk. I can get a heart attack, I can get a stroke, or I could get cancer or something like that. And that is one reason why, as you grow older and you are at greater risk to these kind of ailments, the insurance premiums also gallop, and which should not be actually happening. And I mean, if it's a kind of a equitable model, so that is why insurance, which relies on market principles, is something that we don't want. Another arena that I would like to address is in terms of our public health system. And yes, Corona exposed the fault lines of the public health system very badly. At least in the first phase or the first cycle of Corona, just in the previous year, we did at least good firefighting. I think what I got out of Shailaja's presentation is that the public health system, though it is poorly funded and the infrastructure is weak, etc., but they are at least capable of doing good firefighting. And that is what it did. That is what the BMC did. They did good firefighting. So we did good firefighting to eliminate smallpox. We are doing some firefighting to eliminate polio, and so on and so forth. So there could be various examples. So this, whenever there is an epidemic or a pandemic, we respond to it, but we do not create a system of healthcare which would take care of all these issues when they happen, and we don't have to do firefighting. Yes, actually, I missed something. I mean, I was talking about the three middle classes. So one, which I explained, the second, and the third is what Shailaja showed at the 36 crore. Probably it's more. a population which neither can afford insurance, nor are they are, because they are not below the poverty line, they cannot get benefits from the government. So they are the people who are the most vulnerable within, as far as healthcare access is concerned, especially when there's a catastrophe. They can manage the day-to-day illnesses and outpatient care, etc. Incidentally, the out-of-pocket expenditure, about 60% of out-of-pocket expenditure is for outpatient care. So hospital care is just maybe 30-35%. And again, within that's 60%, which is for outpatient care, about 80% of that is on medicines. So, if the government can do a simple thing within the public system, which was set out in the HLEG report and the 12th five-year plan, that to provide free medicines in all public facilities. If you do that, and you are sure that when I go to a public facility, I get free diagnostics, I get free medicine, the footfall will increase. And this has been shown in Maharashtra, where there's community-based monitoring and planning happening in those 16 districts. Footfalls increased because there was pressure from below for the public health system to respond to the needs of people. So people will go, if they don't find a particular medicine, you're giving a prescription, you send it to the DHO. And the DHO is flooded with SMSs on his phone, and that he has no choice but to see that procurement enables that particular PHC or CHC from where that thing has come. So basically what I'm trying to say is that if we had a good, robust, comprehensive primary healthcare system in this country, we would not have kind of been left in the lurch when Corona hit us, whether in the first wave or the second wave. And Shailaja gave various examples of various districts. I think there's another outstanding example of Nandurbar district, where Dr. Rajendra, whatever, he's an Adivasi doctor, who had the foresight. I mean, Nandurbar was not at all affected, not a single death in the first wave. Okay, but he planned for oxygen cylinders, and he has surplus of oxygen supplies, which he's giving to neighboring districts. So there was a good district collector who kind of responded, who had the foresight, even when his district was not affected. So, but yes, I mean, these individual stories are good, but then I think if we have a proper system, then every district would have the same kind of story to tell. As regards, again, the PMJAY, I mean, the latest data that one has is for September 2020, where 15,500 crores since the inception of PMJAY has been paid out as benefits, whether it was through a trust fund or through insurance, etc. But 75% of the payout went to private hospitals. So in effect, what this means is that public funds are subsidizing the private sector via insurance or other modes of financing. So I think, and there's a tendency for the Ayushman Bharat PMJAY portal to hide these figures. You get them in some corner of a policy brief, which was written by the National Health Authority. They bring out policy briefs. But unlike the RSBY portal, which was very transparent, which gave you detailed information on the types of illnesses being treated, gender differentials by type of different ailments for different states, etc. So those kind of details you don't see on the PMJAY website. They bring out a fancy coffee table annual report every year with a lot of color in it, but no substance in it. So that's the unfortunate part. There's only one page where there are some blocks which say we spent, as they don't give annual data, they give you data as of September so and so we have spent 14,000 crores or whatever. So that's the unfortunate part. Complete lack of transparency is there. In fact, the insurance sector has more transparency in that term, that at least IRDA brings out an annual report which gives you reasonable amount of, I would like more data, but like state-wise data should be published, but it doesn't publish it. It just tells you that there are 4 or 5 states which account for 60% of premiums income, and they mention that. And Maharashtra and Karnataka are 2 of the prominent ones. So insurance is a issue. The poor investment in the public health system is an issue that we need to deal with. And I think unless we do that, whether there may be another corona third wave, or whether there may be another different pandemic or any other kind of basic healthcare issue, we are not going to be able to handle it. And our system, as I keep saying, is only has the capacity to do firefighting if you spend only 1% of GDP. If you actually double that, I mean, you will be able to fill up the vacancies. There are huge vacant positions in across the country of doctors. In primary health centers, 40% positions are vacant. I mean, how can you run a primary healthcare center if 40% of the doctors are missing? Or community health centers, which are supposed to have specialists, 70% vacancies for pediatricians, for gynecologists, and so on, whichever the specialists are required at that facility. District hospitals have a shortage of 40% of doctors. So how can you run a public health system with these kind of deficits? I mean, human resource deficits, medicine supplies are not there, the diagnostic equipment is not working, X-ray machines or MRI scans wherever there are, ultrasound machines. So there are all these issues, and they cannot be dealt with in 1% of GDP. You need to increase the budget substantially. And even that 1% is not fully spent. The health ministry has a history of spending only 80 or maximum 85% of the budget which is passed by parliament and the state legislatures across the country. Some states do better than the others, but generally the overall average is that. So my final word is we need to bring in comprehensive primary health care, building on this health and wellness center concept, because what was missing in the primary healthcare system in the country was robust curative care, which is what, you know, care for NCDs, for access to medicines and diagnostics. If that is brought in at the level which is of 3,000 population, which is closer to people, then I think the faith and the credibility of the public health system, the faith in the public health system and its credibility will increase, and footfalls will definitely increase. And we have seen this where, so there are states like the northeastern states like Mizoram, Sikkim, who spend 5 to 6,000 rupees per capita. Even Lakshadweep does that so well. Incidentally, Lakshadweep was one state which did not have a single case of coronavirus till the administrator changed and he opened Kochi airport and the ships or whatever to the port to travel to Lakshadweep. And after that happened, within 15 days, Lakshadweep saw 1,000 cases and a few deaths. This was purely an administrative action which went wrong terribly. And we know what the mess is happening in Lakshadweep. I mean, it's a kind of a Hindutva, another kind of Hindutva experiment. I will not get into that. So I think I'll stop there because there may be people waiting to ask questions. And if there are any questions, I will respond to that.
Right. Thank you so much, Mr. Ravi Duggal, for your points presented in a very precise manner to all of us. And it would definitely benefit our viewers. And indeed, we have certain questions from our audiences. Since we have overshot our time limit, I would request Shailaja ma'am that there are two questions. I would request her quick reaction to these two questions, which we have got from the audience during the discussion. Our first question is, ma'am, only over 6 lakh people avail Ayushman Bharat for COVID treatment. The numbers are interesting. Bihar only saw 19 people availing treatment under the scheme. For Uttar Pradesh, the number is 975. And as far as Jharkhand is concerned, 1,419 people were treated. Why this scheme is not helping people in the poorest states?
I have not seen the figures that you're referring to, but if they are correct, then it points to the fact that the poorest, whom it was initially designed and for whom it is meant, are either not aware that it exists, or the systems to make it possible for you to avail of treatment are not there. I wonder whether all the packages also had a specific mention anybody with COVID can get a free treatment. I have no idea. So I wouldn't be like to just hazard a guess. But if the numbers are correct, then it's a very, very dismal picture.
Right. And ma'am, one more question is there. The media was full of stories of profiteering by private hospitals. And it says as first, should there be some authority regulating the charges? And second, can the private sector give affordable treatment to the shattered middle class?
No, there are two questions which you're putting, and we have been discussing it for the last about a couple of hours, the same issue. It's very clear that the private sector, that is the large corporate chains, have come as a result of policy permitting foreign investment, and also the fact that they could expand as a corporation, not as a setting up a hospital. They could set up chains and they could bring in foreign investment. Having, they will look for a return on investment. That is obvious. But when they will stretch themselves to be able to cover the middle class, it's impossible unless the insurance pays for it. And as Ravi just said, nobody will be able to afford it. You have to pay out of your own pocket or your own pension. It's unaffordable to go there. Charges are so much, but the fact is that if insurance pays for some of it, but then there are other hidden problems. I'm not an insurance expert, but if you have registered and you are, you've said you'll be okay with the 2 people in a room. During COVID, you obviously couldn't be 2 people in a room. It had to be 1 person. So obviously costs will go up. So somebody look at this. You cannot just leave it to the hospitals to say one thing, say something else. I would say that they will not measure up. They will certainly do what is in their own interest, unless there is a requirement which is reasonable, that they would have to be within the 4 walls of something that the government policy lays down. As of now, there is no such thing. And I mean, since I've worked in power, I know how seriously the power, you might say the discoms, the district, even if they're government run, they're very bothered about what happens in terms of orders given by the State Electricity Commission and the Central Electricity Commission and the Appellate Commission. These things are taken very, very seriously. Same with
That's a
SEBI.
question from Dr. Charan Singh.
Thank you.
Can I add to what Shailaja said? I mean, in terms of the private sector overcharging, the Maharashtra government actually got auditors to go to these large private hospitals to audit the bills that were issued to patients. And this was in the first wave of the COVID. So sometime in August and September, this was done. And they were able to actually, and people were complaining that this audit is not complete, but still 15 crores was returned by these hospitals. And most of it in Mumbai, and then the biggest culprit was now just one hospital, Nanavati Hospital, where the likes of Amitabh Bachchan and others were treated. So there's definitely an issue about strengthening regulation. And unfortunately, the Clinical Establishment Act is very poor. And the 5 or 6 states which have implemented it, it's an irony actually, which have actually passed that bill and have included it in this thing. There are states which don't have a significant private sector. So that's, that's the,
Right.
all the hill states have done it, where private sector is very weak. So we need something much more. We need a SEBI kind of regulator for health, or IRDA or SEBI or something like that. So unless we, as Shailaja said, unless we have that kind of regulation, I mean, the private sector is going to have a gala time and going to fleece us and exploit us and profiteer thoroughly.
So there is one more question which says that what are the recommendations for the future?
Well, I kind of said, and we have to set up a good comprehensive primary healthcare system. We need to, so that I talked about, so I will not re-emphasize that. Then our district hospitals need to be converted into tertiary hospitals. There is a plan to do that, that make every district hospital a teaching hospital, but not the way the Niti Aayog says. Their prescription is public-private partnerships. Public-private partnerships have failed in this country miserably, except probably ambulance services. That's the only one I can think, which, or maybe some programs for a while, the partnership with private doctors did work. But as a whole, I think our system is incapable of dealing with that. So we don't have the capacity to kind of regulate that. And so we strengthen the district hospitals. You have a good primary healthcare system which functions like, say, the NHS, where the primary healthcare system becomes the gateway for higher levels of care.
Right.
I think that is what we need to strive for if we are talking about equitable, universal access to healthcare. So
Right.
that's the global experience. I mean, we know the mess that US is in. That's the only country which actually has a large-scale health insurance financed healthcare system.
Right.
But look
Right.
at all the other capitalist countries in Europe, Japan, Canada, Australia, all of them, 85% of the budget comes out of taxes for healthcare. At the point of care, people don't have to pay. You pay when you're working, and once you retire, you don't have to pay these high insurance premiums that we are forced to do so in this country. So that is the kind of system we need to. We need to universalize social security. I think that's the only way out, which will cover health and other pensions, etc., and so on.
Right.
And Charan Singh ji is asking one question.
There is one more question, which says,
Can you just switch on the no, allow him to speak himself?
Yeah.
There's a question on manpower.
Charan Singh ji, please.
Thank you so much for giving me this opportunity. Very, very intelligent people on the forum and so beautiful presentation. Really thanking Mr. Nair to request and invite such good people and experts. My question is, when the second wave hit us, we were all taken aback, and all of you have summarized it so well. And if the third wave is coming, what is, of course, all the things that you're mentioning, the primary health system, the district hospitals becoming tertiary, having a regulator, these are in the medium to long term. I was looking at experts that you are. What should we be doing in the third, fourth, and the fifth wave? And that probably would be recommendations which health ministry can, Niti Aayog can, the government can swing into action and sort of mitigate the impact of the third. Thank you for again giving me the time to ask this question.
Anybody wants to go for that?
Shailaja ma'am.
There is one question which I see on the chat box about human resources, about the lack of manpower. There's no lack of manpower in this country. I mean, we are overproducing doctors, in fact. But these doctors do not go to the public health system. That's the issue. So you need to change your human resource policy of how you employ doctors or even nurses. We produce doctors and nurses for the world. Every year, 5,000 doctors are leaving this country after getting education here, and they're working in the Middle East or US or Canada, Australia, wherever else. So it's not, we're producing 65,000 MBBS doctors every year. We don't need more than that in this country. provided you can get them. I think if the government has the political will, a simple act of compulsory public service for 1 or 2 years is enough. 65,000 doctors, don't even have half that as PHCs. We have less than 30,000 PHCs in this country. So let everybody go there by rotation. Why don't so we need a new health human resource policy, and these are things we need to we produce. Why do we produce for the world? Why do we create corporate hospitals so that medical tourism happens in this country when we can't treat our own people and give them good healthcare access? So I think these are political questions which have to be asked and which the politicians have to respond through through progressive social policies.
Yeah.
I think we must also be practical. Whatever has happened with health sector, allowing the foreign direct investment to come, and it really came at the fact that in those years people were going abroad for heart, you might say, bypass and things like that, and it was huge amounts of foreign exchange had to be paid for getting that done, and that only a very small segment was able to do it. And by India taking the lead and saying, all right, we will open up the doors. After all, India didn't have the money to invest, and nor did Indian business initially invest. So the private sector, the corporate sector came up, which is 4 to 5%. When we talk about hospitals, it's very, very different from public health and primary health. I think that understanding, the people who have taken the trouble to sit through this webinar should be aware that we must really be very conscious that when we talk about primary health and public health, these are completely different from medical health as given by hospitals, particularly in emergency situations like an epidemic or something like that. So it's very clear we can't do everything. There's no way that this country is going to do everything. So if you have to triage and decide what really comes first, I would say that the fact that the corporate hospitals have come through a policy, they can't all be shut down. They can't suddenly be made into missionary. That is something which you just can't do. But how can you enter into a relationship whereby the COVID has taught us that they do listen if the government asks them things? So certain things, if they are supervised, a certain, you might say, arrangement is beneficial to the public can come into place. And that is something to do. Networking between hospitals, having access to certain beds as absolutely under your control to be able to assign people to those from the public side is something which is quite possible without having to fold up all the private hospitals. There's no way that India can afford to set up that. And I feel very bad that when all actually did do some service during the pandemic, and people were begging and pleading with me, please get us a bed there. If they were so bad, no one is going to be asking. There were doctors who were competent. There were nursing stations which were run properly. So we should it. Now, if the managements are profiteering, well, just as you gave the Ravi of 15 crores having to be paid by one particular hospital or some group of hospitals in Mumbai, we do need that kind of audit. Why are we not doing the audit? That doesn't mean that everything that is done is bad because it is private. It needs to be looked into, certainly, but partnerships between government and the private sector came out very well during the COVID pandemic, and those need to be built upon and have standard operating practices. If A happens, this will happen. If B happens, that will happen. So I feel that we must build on our strengths and not decry that goes. But having said that, I would say that the country faces a huge problem ahead, not in terms of pandemics alone. We are sitting on a bomb in terms of diabetes and heart problems because of our lifestyles, and it has percolated into rural areas. I'm on an NGO called, and it deals with women and children and poorer people. The workers say that the children have kurkure packets in their bed, and this is what they fill their stomach with. They eat papad and fill their stomach with. Because of hunger, it's become a way of life. You don't eat chapati and dal anymore. Obesity is taking place even among the rural poor. So with these things happening, I think that one has to be reasonably clear that prevention of ill health is very much a government responsibility. No private sector is going to do that. Why don't we judge how much ill health was prevented as compared to always finding fault everybody and everything? Our public sector is the pits, our private sector is avaricious. Then where are we? We will never be able to cross these hurdles in the next, at least certainly not in my lifetime, even in yours, Ravi. So I think we should be practical and work on our strengths, which are many, and we should not put those down. But regulation is a must. If you everyone, you and I will run amok if there's nobody to supervise what we're doing.
Right.
Okay. That point of Smriti, I'll just intervene here. That point of 5% only these corporate hospital, and not make a big discussion on that, because it's work on a different dynamics is well taken. But what I am wanting the discussion to focus is the large chunk of non-governmental, non-profit or medium profit institutions. That's a large chain in which a lot of regulation in the sense of following standard treatment protocols, or not overcharging the bills, and all those quality parameters to be applicable to the large sector of private sector, which is medium size, and which is, as in your terms, the secondary care. The primary care, no doubt, it is the public health system's primary care is taken over by the government, and it is doing so in many decades. But what is missing is the secondary level care, or to some extent even tertiary level care that government hasn't been. And that is where the expansion under the universal health coverage, the secondary and tertiary care was attempted by National Health Mission of additional inputs and skill development and all. So where each CHC is supposed to deliver, sub-district hospital to deliver specialty care, which unfortunately, as Ravi puts it, about 75 to 80% of vacancy. So that is one issue. Then to supplement that, the private nursing home and middle level hospitals giving care, but at a compromise way in quality and overcharging. That has to be regulated. There is one question to me specifically in the chat box. This Clinical Establishment Act will lead to license rats. I agree with that person who asked that question. It can, because wherever there is a power given, misuse of power can happen. What we need is appellate authorities in every district, under district magistrate and all, where grievances can be addressed, and there are more civil society members there as a watchdog. That is what Jan Sunwai and all Jan Swasthya Abhiyan did in North Karnataka and Maharashtra and all, where even the license Raj, tendency of license Raj enforced about middle level hospital, and some of them are very good charity hospital, mission hospitals, some voluntary sector hospital, not so much of a profit, but hand-to-mouth existence sort of institution. They were curtailed by this Clinical Establishment Act. That should not happen. So that is the future we have to look forward, strengthening the middle tier and leave aside that 5% of Fortis and all. Let them. They are delivering quality service. They are charging high. There is a need for regulation. That is underlined. All the speakers have said that. Let us emphasize, underline that point. Regulation is a must in the private sector, and we cannot avoid living with private sector, because 65% of the care is given by healthcare is given by private sector, and out of which corporatization is only 5% or 8% max. I would.
All right. Thank you so much, everyone. And I would now, since we are really falling short of time, I would now request Mr. Anil Nair to kindly speak a few words and close the program.
Thank you, Smriti. I don't think I should speak. I should be speaking now. because the people are really impatient. So I would like to thank you. Thank you, Shailaja ma'am, Dr. Antony, Nagaraj Sharma, and Ravi Dugal for this illuminating discussion. We will come back next week with the third discussion of the series towards a robust healthcare system in India on Saturday at 5 p.m. Dr. Antony will be there, and Dr. Aruna Sharma, former Secretary, Ministry of Steel, Dr. Sundar Raman, former Executive Director, NHSRC Delhi, Dr. Yogesh Jain, Jan Sastya Abhiyan, and Dr. Rama Baru, Professor, Center for Social Medicine and Community Health, JNU, will be there. Once again, I wish to thank all the speakers and the audience for joining us in today's discussion. Thank you very much.
Thank you.
Thank you. Shailaja ma'am, I really wanted your last 3-4 slides. You couldn't explain because I really want to study it. Excellent information. And also Mr. Sharma gave